Welcome back to RNStudyHub. Today we're covering lithium, one of the highest yield medications you'll encounter in psychiatric nursing. Lithium is a powerful mood stabilizer used to treat bipolar disorder. Lithium could be considered the gold standard mood stabilizer, but it has a very narrow therapeutic range, meaning even small changes in dosage can cause toxicity. Because of this, nurses must understand monitoring, labs, side effects, patient safety, and toxicity symptoms, most importantly. Make sure you stay until the very end of this lesson because we'll go through practice questions and answers to reinforce everything you've learned. Before moving on to the mechanism of action, I would like to request if you guys could please like this video and subscribe. Liking and subscribing will help this channel out. So for the mechanism of action, lithium is unique. It's actually a simple salt. It's not an antidepressant or an antipsychotic. Its main effects are stabilizing neuronal firing, decreasing dopamine, increasing GABA, calming hyperactivity in the brain. Also, it is very important for you to know that it takes 1 to 3 weeks for it to reach full therapeutic effect, and it's highly effective for mania. This is why patients often need temporary antipsychotic or benzodiazepines while they're waiting for the lithium to work. So, if you get a question in your class or on the NCLEX and it goes something like, does lithium provide immediate relief during acute mania? The answer would be no, because lithium takes 1 to 3 weeks to reach full therapeutic effects. So moving on to indications, clinical indications for when lithium is used. Lithium is used in bipolar 1 disorder. Like we've spoken about before, it's used for mania. I know sometimes it's going to be like I'm repeating myself over and over, but these are very important things to memorize and to know as you start working as a nurse. Bipolar 2 hypomania is another indication. Long-term mood stabilization, especially in between episodes. Adjunct treatment for depression. Also, lithium is not used for rapid calming or emergency agitations. Another way that someone could say emergency agitation is if they'll throw in the word psychosis. This medication works slowly. Like we said, it takes 1 to 3 weeks to take full therapeutic effects. And like I said, patients might actually need an antipsychotic or benzodiazepine until lithium becomes effective. So, while we're learning, if you are in class and they're asking you which condition is lithium is primarily prescribed for, or you see something like this similarly on the NCLEX, the answer would be bipolar disorder, especially manic episodes. Moving on to therapeutic range and monitoring for critical nursing knowledge. This is the most testable nursing concept. I'll probably spend most of my time explaining this slide. The therapeutic range is 0.6 until 1.2 milliequivalents per liter. Therapeutic, that is therapeutic. Okay, so early toxicity is above one. I always say above 1.5, but they could still have 1.5 and they're showing you signs and symptoms of toxicity, which we'll get into later. But anytime you see 1.5, I will be calling the doctor. I would hold the dose and clarify the orders if he wants to continue or to see what the doctor wants to do. Severe toxicity is above 2.0. And a medical emergency, this is life-threatening, would be above 3.0. Another important thing to know is lithium is 100% excreted through the kidneys. So a renal function draw matters, like to check these levels matters. Now, to get into to when you're supposed to draw them, it could be there could be a little caveats. They could ask you questions regarding when, depending on the situation. So yeah, it's 5 to 7 days after starting lithium, or they could change the dose. that's when you'd have to do that again. You'd have to draw a level within 5 to 7 days. Another time is for the 8 to 12 hours after the last dose. Sometimes doctors are in a rush and they do make mistakes. They're human just like us. We could make mistakes too. They might order you to give lithium at, I don't know, 7 a.m. and they have lab draws for a lithium level at 8 a.m. You should automatically know that you're supposed to draw within 8 to 12 hours. So if you gave the lithium at 7, you shouldn't be drawing a lithium level 1 hour after. It could mess up the levels, and that's an error, and it could affect the patient in a negative way. So you would have to do, in my hospital you have 1 hour before, 1 hour after to give the medication from when the time it's due. So if it's due at 7 but the lab order is at 8, just draw the lab at 7 and then give the medication within the time range that you're allowed. But do the draw first. And make sure the last dose that the night shift nurse gave is within the 8 to 12 hours after range dose or administration, should I say. And then also for a patient, when they're stable, so let's say you're a nurse that works outpatient in a psychiatric clinic, or you work in a regular clinic and your patient just has multiple diagnoses. Anybody could have mental health disorders. So it would be, you're checking the labs for the doctor when the last lab draw was for them, and you see that you're doing their intake, you're going over their medications, you see that they're taking lithium, you see the last time they went to get labs was like, I don't know, 4 months ago. You might want to mention that to the doctor. Another time is, which is not listed on this PowerPoint, is if the patient is showing signs or symptoms of toxicity. That's when you hold the dose, and that would be another time you would have to draw a level to see where it is. Anything could affect these levels. Like I said, kidney function is important. Salt intake, fluid intake. If the patient has diarrhea, if they're vomiting, that all could affect these levels, and they could get toxic really fast, and it could be potentially life-threatening. So also, this could be, like I said, the most testable nursing concept when it comes to lithium. So remember the NCLEX in your class as well. Your teachers could use select all that applies. They could use different scenarios. They could ask you a select all that apply question where you have to know when you're supposed to do it. They could be all 4 of the ones that I gave, 5 to 7 days, 8 to 12 hours after the last dose, 1 to 3 months once the patient is stable, or if the patient is, experiencing toxicity. It could be those 4 correct, and then the 5th answer is wrong. So you'd have to pay attention to the question, or they might ask you which one is wrong, and then the 4 are right, and you'd have to choose the wrong one instead of choosing the 4 right ones. So they kind of, you have to pay attention and read the question. I always read the question twice, and I read the answers. You don't want to miss points on stuff that you're just nervous to take the test. So, as we go through this lesson, I'll be making up questions as we go. When should a lithium level be drawn? Pick any of these 4 answers that I gave you. 5 to 7 days after starting or changing the dose, 8 to 12 hours after the last dose, 1 to 3 months once the patient is stable, or if they're showing signs and symptoms of toxicity. You repeat, and the more that you repeat it, the more you say it, the more you write it down in your notes, the easier it is going to be for you to remember these topics. Okay, moving on. We'll be going into lithium toxicity, life-threatening condition. Lithium toxicity escalates fast. Early is 1.5 until 2.0. Moderate or severe is from 2.0 to 2.5, which is in milliequivalents. Severe toxicity is above 2.5, from above 2.5, or sometimes you'll see above 3.0 milliequivalents per liter. The early signs, nausea, vomiting, diarrhea, fine tremors, muscle weakness, increased thirst and urination. Sometimes it looks similar to like GI upset. Always question new nausea or diarrhea in patients that are taking lithium. Some other signs or symptoms in moderate toxicity could be confusion and delirium, balance problems. They can't walk right. They have they have ataxia. You're looking at their gait, doesn't look normal. They have coarse tremors. Their speech is slurred. They have lethargy. They just want to sleep, or they don't want to do anything. And then severe toxicity, you have seizures, coma, cardiovascular collapse, low blood pressure, low heart rate, and that patient could escalate really quickly. It's a medical emergency. Immediate actions: stop lithium, notify the provider. Sometimes they're going to prepare the patient for a gastric lavage or hemodialysis, and to rehydrate the patient as well. Nursing priorities: essential monitoring and assessment. Monitor lithium levels frequently. Maintain therapeutic range between 0.6 to 1.2 milliequivalents per liter. Assess kidney function. Regularly check BUN, creatinine levels. Assess thyroid function. Monitor for hypothyroidism. They could be at risk for hypothyroidism. Check the TSH levels. Monitor fluid and electrolyte balance carefully. Watch for early signs of toxicity, especially GI symptoms and tremors. Encourage stable sodium intake. Low sodium increases lithium levels. Ensure adequate hydration. 2 to 3 liters per day, unless contraindicated. And remember, lithium acts like sodium. When sodium drops, kidneys hold on to lithium. Moving on to patient teaching. This is a critical nursing safety information. You want to go over medication management. Take the lithium exactly as prescribed. Never double dose. Never take 2 because you miss 1 dose. Keep all your follow-up appointments. Go to your lab appointments. Stop lithium during severe vomiting, diarrhea, or excessive sweating. If you have the flu, if you have diarrhea, if you're vomiting, if you're doing all 3, don't take your lithium and call your doctor. That's what you should be telling the patient. For lifestyle management, maintain normal, consistent salt intake daily. Drink 2 to 3 liters of water per day. Avoid dehydration from exercise, heat, or if you're having illness like vomiting, diarrhea. Also, avoid NSAIDs like ibuprofen. They increase lithium levels. Avoid diuretics. They affect lithium excretion. Lithium is safe when blood levels are stable and monitoring routines are followed. You have to follow them consistently. The dangers happen when labs or hydration habits are ignored. Now, it's time for the high-yield NCLEX summary. This is your must-know facts for lithium. Therapeutic range is between 0.6 until 1.2 milliequivalents per liter. Memorize this. Early toxicity, GI upset. So if your patient has nausea, vomiting, diarrhea, you're going to want to start thinking, is this patient getting signs and symptoms of toxicity? Plus, especially if they have tremors. Severe toxicity. Maybe they're having neurological symptoms, they're confused, they're having seizures, they go into a coma. You're supposed to draw the level between 8 to 12 hours after the last dose, or if the dose changes, for accurate trough levels. So you're supposed to memorize. The patient's supposed to maintain adequate hydration, 2 to 3 liters per day, and consistent sodium intake. Avoid NSAIDs. and diuretics both increase lithium levels. If you understand these 6 points, you can almost answer any NCLEX lithium question with confidence. Okay, now it's time for the practice questions, which is testing your knowledge. A patient on lithium reports diarrhea and tremors. What should the nurse do first? I'm going to give you guys about 5 seconds to answer the questions. Take a moment to consider each question before moving to the answers. Think about therapeutic ranges, toxicity signs, and nursing priorities. Okay, so the answer to question 1 is hold the dose and assess for toxicity. Number 2, which lab value must be monitored closely with long-term lithium use? I'll give a couple more seconds. I'll let you guys think. Remember, write down these questions. Thyroid levels is the answer. TSH. Number 3. Oh, I see here I put number 3 two times on the PowerPoint slide. A dehydrated patient on lithium is at risk for what? So I'll give you guys about a couple seconds. A dehydrated patient is at risk for lithium toxicity. Number 4, which electrolyte interacts with lithium levels? I'll give you guys a couple seconds for that as well. The electrolyte that interacts with lithium levels and affects drug retention is sodium. Low sodium increases lithium retention. And number 5, a lithium level returns at 2.4 milliequivalents per liter. What is the priority nursing action? I'll give you guys a couple seconds again. The priority nursing action is notify the provider immediately. This level indicates moderate to severe toxicity. And here is the slide that goes over the questions and their rationales to reinforce your learning. For question number 1, you would hold the dose and assess for toxicity, and the rationale is because diarrhea and tremors are early signs of lithium toxicity, requiring immediate evaluation. For question number 2, it was TSH thyroid levels because long-term lithium use increases risk of hypothyroidism, requiring regular thyroid monitoring. For question number 3, it was lithium toxicity because dehydration causes lithium retention since lithium is excreted through the kidneys, leading to elevated toxic levels. Number 4 is sodium. The rationale is because lithium acts like sodium in the body. Low sodium causes kidneys to retain lithium, and that increases blood levels of lithium. And number 5 is notify the provider immediately, and the rationale is 2.4 milliequivalents per liter indicates moderate to severe toxicity. The normal range is 0.6 until 1.2. This is a critical result, the critical result being 2.4, requiring urgent medical intervention. Understanding the reasoning behind each of these answers builds on your clinical knowledge and your judgment, and that's essential for safe nursing practice. If you made it this far, thank you so much. Don't forget to like, don't forget to share, don't forget to comment if you appreciated it. Don't forget to subscribe. Thank you so much for learning with me, with RNStudyHub. Study smarter, nurse stronger. If this lecture helped you understand lithium pharmacology more clearly, share this knowledge with your classmates and continue building your nursing expertise. Thank you so much and see you next time.